Good morning, everyone. My name is Alana Dillon. I'm an Education and Support Services Coordinator with Parkinson's Society BC, and I'll be facilitating our webinar today. Thank you for joining us this morning for our Ask the Expert webinar on bone health in Parkinson's with Dr. Naaz Parmar. Before we get started, I wanted to go through a few housekeeping items. First, I want to let you know that the slides and webinar recording will be available on our website after they are processed. It usually takes about a week. Secondly, you will see a chat box at the bottom of your screen, or an icon rather. If you click on that icon, the chat box will open for you to type your questions. And finally, to optimize your experience with this webinar, please ensure that you adjust your speaker volume both on your computer as well as on your actual speakers so that you can hear the webinar well. I would now like to introduce Dr. Parmar. Dr. Parmar is a clinical instructor for geriatric medicine and internal medicine at UBC, based at Vancouver General Hospital. She also provides outreach specialty clinics for geriatric medicine at the University Hospital of Northern British Columbia in Prince George. She has an interest in acute care medicine as well as outpatient care, hoping to streamline the transition from hospital to home and preventing hospital admissions with consistent, comprehensive outpatient care. Quality of life and multi-pronged treatment plans involving exercise and medical care are also a focus for her. She has a passion for teaching and is active with medical students, internal medicine specialty residents, and geriatric medicine fellows. I'd like to pass it over to Dr. Parmar now. Dr. Parmar, welcome, and thank you for being here today.
Thank you so much for having me. I really appreciate being able to talk on this subject. Bone health is something that I very much focus on in my practice. And I hope that this will be a useful talk for all of you. I have tried to keep quite a bit of time at the end of this talk. So if you do have questions, feel free to jot them down and we can discuss them at the end. I am hoping for that with just so many participants. If we do stop it during the slides, we may fall behind and not be able to complete the entire talk. But if you feel comfortable at the end, you can put them into the chat, or you can also use your mic and connect in as well if you prefer that. Okay. So we're going to start by having an overview of what is bone health exactly, and the medical term for that is osteoporosis. We're then going to speak on the effects of osteoporosis on your general health and, more importantly, your quality of life, how it actually affects you day to day. We'll then shift towards the connection between Parkinson's disease and osteoporosis, how you are at greater risk for osteoporosis and why that risk is there. That will also lead us into talking about medications, specifically the Sinemet and other dopamine-based medications that many people with Parkinson's are taking and that raise questions about bone health. We'll move then into the treatment options for Parkinson's disease, and specifically treatment options that are targeted towards people with osteoporosis and Parkinson's disease. And at the end of it, we'll go through some questions. Okay. So the first question is, what is osteoporosis? So osteoporosis is actually a metabolic disease. So that means that it is a disease that is managed by hormones. Our bones are naturally constantly broken down and built back up, and that happens from the time of birth up until our very last day. That is all driven by a balance of hormones. Certain hormones tell our bones to break down. Other hormones encourage our bones to build back up again. And when that is in balance, we have nice, strong bones that have a strong network within the inside of the bone, so that if there is a force, such as a fall or a pressure or an accident, that bone has enough strength to hold its shape, to hold its integrity. With osteoporosis, that balance is lost. And so our bones break down much faster than they build up. And if you can imagine that, if you're having far more breakdown, the inner scaffolding of your bone is not as strong as it needs to be. And so you are at greater risk of having a fracture, of having a broken bone. With osteoporosis, we know that you have an increased risk of all fractures, but more importantly, we worry about the fractures that affect your day-to-day life, the ones that affect your mobility, the ones that affect your ability to do necessary tasks. So those are usually fractures of your long bones. And by long bones, we mean the big bones, usually of your limbs. So your humerus in your arm, your femur in your thigh, the top of your hip. We also worry about the bones of your back, and those are called your vertebrae. And those are important because your vertebrae not only help to hold your skeleton up, but they also are where all of your nerve endings come out of. And so a fracture in your back, of course, can have many consequences. And these are the bones that we worry about in osteoporosis. As you can imagine, that's a lot of fractures out there. And we know that it is actually a lot of people within Canada who are also suffering from osteoporosis. So the most recent census data that we have did show that over 12% of the population, or 2.2 million Canadians, are actually suffering from osteoporosis right now. So an important disease to look at, as it is affecting many people. Now, how do you diagnose osteoporosis? There are actually two ways to diagnose osteoporosis. The first one is based upon your history, and that's the history of a fragility fracture. So when we fall, the weight of our body should not be enough to break our bones. If you fall from a standing height, so that is, say you're standing on the sidewalk and you fall down onto that same sidewalk, that's a fall from standing height. If you fall and you suffer a fracture, we say that your bones are too thin in that situation. They should not have fractured in a normal case. So that is weaker than average. So that is considered an osteoporotic fracture. There are other fractures that can also happen that aren't just from falls. Some people have severe enough osteoporosis that simple actions like bending or lifting something of a moderate weight. So a moderate weight would be something that, say, would be 10 pounds or 15 pounds. So bending down and lifting something like that can also cause a vertebral fracture in some people. Now, again, we should be able to easily pick up 10 or 15 pounds without breaking our backs. So that would be considered too fragile, too frail. That is one of the diagnoses of osteoporosis. There is another way to diagnose osteoporosis as well, and that is based upon a test of your bone strength. Now, this is done through radiology, so through imaging, and it's a special test that's done through nuclear medicine. Most major hospitals will have a nuclear medicine department, and a lot of the private radiology labs out there as well will do them. If you live within the Lower Mainland, you've probably heard of Brook Radiology or Grieg Radiology. Places like that are able to do it as well. So a bone mineral density is a test where you go in and you have an injection of some markers that actually adhere to your bones, and they light up on the pictures to show us how strong your bones actually are. Based upon how well your picture lights up, we can compare the density of your bones to a normal average. And what we do is we look at that average and we say, how far from normal are you? Now, there are some people whose bones are stronger than average. And of course, there are many people whose bones are weaker than average. And we use something called a bell curve, which anyone who's done statistics will probably cringe as they hear that. But we use a bell curve to look at that. And we use that breakdown of standard deviations. So we say that the cutoff for osteoporosis is if you are less than negative 2.5 standard deviations below normal. So with looking at that mathematically, that is usually people who are in the lower 5th percentile of bone strength. So the very, very tail end of the strength there. And you can see in this image that I've put up here that they have the markers there of less than negative 2.5. And you can see that there's not much under the curve left there. So that is actually quite weak compared to normal. There is also something else called osteopenia. Now, osteopenia is an at-risk situation. That is where we say your bones are weaker than average. They're not weak enough to be called osteoporosis, but you should be aware of this, and we should try and prevent you from progressing on to true osteoporosis. Okay. Now, we know how to diagnose osteoporosis, but who should we be screening for osteoporosis? And to be honest, it's most people. We know that everyone over the age of 65 is at risk of developing osteoporosis. And as such, in British Columbia, the guidelines are for everyone to get their first bone density at the age of 65, regardless of your medical health. Everyone should be getting that. And it's actually suggested to have a bone density done every 3 years after that. That is very similar to the guidelines across the rest of Canada and across the rest of North America and Europe, is that we know 65 is really a risk factor. Other than age, which is something we can't change, there are a few other medical issues that put you at higher risk. One of them is just simply a history of having a fragility fracture in the past. Of course, if you've had a fracture before, we need to monitor your bones and track them through time and see what your risk is changing to. Is it getting better? Is it getting worse? There are also some medications that can put you at higher risk of having bone density issues. These are medications that affect your hormonal balance, and one of them is steroids. Glucocorticoids, prednisone being the one that most people are aware of, is a common one that we look at. That can be prescribed for a multitude of reasons. The common things are any sort of joint issues, rheumatoid arthritis, any sort of inflammatory issues. People who have COPD are often on this. People who've ever had polymyalgia rheumatica, so severe muscle aches and things like that, they're often given steroids. And if you are on steroids for a prolonged period, so more than 21 days, and at a higher dose, so more than 7.5 milligrams, we know that your hormonal balance of your bones will be affected. And as such, we need to be monitoring your bones and see what's happening with that. Another thing we look at is a history from your family of having a hip fracture. So if either one of your parents ever suffered a hip fracture, you're considered higher risk for developing osteoporosis, and you should be screened with a bone mineral density. Any history of a previous vertebral fracture or any x-rays that might say that your bones look thinner just based upon the x-ray or a reason to get a bone density. Alcohol is also something we have to screen for. Alcohol does have a negative effect on your hormonal balance and therefore a negative effect on your bones. So again, something else that we need to be screening for if you are having excessive alcohol intake. Now, what is excessive? I think every person has their own version of that. But according to our Canadian guidelines, we say that the maximum number of drinks that a man should be having is 2 drinks a day. And for women, it should be 1 drink a day. So if you're averaging more than that, there is a chance that the alcohol is having a negative effect on your bones, and you should be getting a bone density screen for that. Smoking, at any rate, is actually a concern for your bones as well. So again, a history of smoking is a reason to get your bone density done. If you have quit, fantastic. That's a great thing to have done. But if you have had a long history of smoking, and if you were smoking quite a bit, so more than a half a pack a day, that does tend to linger with you as well as a risk factor. So again, something to talk to your doctor about if you have a history of smoking, about whether you should be getting a bone density. Another issue is whether you're carrying enough weight to challenge your bones. So our hormones drive our bones, but also movement drives our bone strength. So if you think about an astronaut up in space, we've all heard stories about how astronauts actually grow a little bit when they're in space because there's no pressure on their bones. We also know that they come back with thinner bones, again, because there's no force on their bones. That same thing can happen if you start to lose weight or if you are low weight down here on Earth. Our bones need to have that weight that they carry around for them to build up. And if you are less than 60 kilograms, then we know your bones are at greater risk of losing strength. And also if you've had a significant weight loss. So that's a weight loss of more than 10% compared to your weight when you were 25 years old. So again, lower weight is something to consider. Rheumatoid arthritis on its own is also a risk factor. I spoke earlier about the steroids that are often used in rheumatoid arthritis, but the disease itself also can put you at risk. And so anyone with rheumatoid arthritis should be screened for osteoporosis. And there are a few other disorders that are also strongly associated with it. Those tend to be more autoimmune disorders where you tend to have a higher risk of osteoporosis. There are also some other medications that can put you at risk. Certain chemotherapy medications can put people at risk as well. And so we have to screen for that as well. Okay, now this is just that same information just put into a chart for you to see, and these are the Canadian guidelines. And you can see there it says anyone over the age of 65. And then those risk factors that I just spoke about are for people who are between the age of 50 and 64. And so any of those history of fragility fractures and such. For adults who are younger than 50, it really is a concern of medications that we look at or other hormonal diseases. So again, if you're younger than 50 and you're on high dose steroids, reason to go get screened. And if you have any other disorders that may affect your hormonal balance, so usually these are premature menopause or premature andropause in men, parathyroid issues, or other things that can actually affect your bone density. Okay. So why do we care so much about bones? And the reason is because they have a huge impact on your life. And one way that we quantify this is something called disability life adjusted years. So that is a measure of how many years of good quality life you lose. And you can lose those years either through debility, so disability, or actually passing away sooner than expected because of the disease. So it really is a loss of quality of life overall. And when we look at this, I highlighted this information from the WHO to give some perspective. We see that Parkinsonism is actually at the top of this. And if you compare that to hip fractures or any osteoporotic fractures, the hip fractures and osteoporotic fractures actually cause you to lose more quality of life than Parkinsonism does on its own. And for those of you who have Parkinson's or are family members or loved ones of Parkinson's patients, you know that Parkinson's has a significant effect on your quality of life. Now multiply that, and that's why we're worried about your bones. Okay. So what are those effects that we see? Well, the immediate effects are pain. A fracture is painful, very difficult for someone to have to deal with, a huge impact on your quality of life. So any sort of fracture can be very painful, but those major osteoporotic fractures, a thigh fracture, a hip fracture, a shoulder fracture, extremely painful. And we worry about that at the start. And of course, when you have a fracture, you have an injury, so you're not able to move around comfortably as you usually would. So those are the immediate issues. Along with that becomes a concern regarding pain medication. So having to use high doses of pain medications. Quite often our usual things of Tylenol or Advil are not enough when you have a fracture. So people are having to use things like opioids, so hydromorphone, oxycodone, medications like this, just to be able to tolerate their pain. That comes with its own concerns. And then you're also worried about not being able to move around as you usually would. So with a hip fracture, you're not able to get out of bed on your own. So how are you going to get to the bathroom? How are you going to mobilize in those ways? If you have a shoulder fracture, how are you going to eat? How are you going to grab things off the cupboard? How are you going to cook? These are all concerns that come up right off the bat, and we want to avoid these if at all possible. Unfortunately, most fractures also leave you with a long-term effect as well. Not everyone heals back to 100%. So often you will have lost some mobility because of your fracture. And you'll also have lost some strength because of your fracture. So you might not get back to where you were before. So it could be that you need to use a walker now when previously you were able to walk on your own. You might need to have other aids as well. So people who've had shoulder fractures often have to use grippers and other devices to help them during their day-to-day activities. Chronic pain can also come about from having a fracture. A change in your posture, if you had a vertebral fracture, is a common one as well. The old term used to be the dowager's hump, where you would see someone who had untreated osteoporosis and they just fracture until they weren't able to stand up straight anymore. That is something that can truly happen and be quite debilitating as well. And also all of this can mean that you're not as active as you were before. That has a knock-on effect on all of your health concerns from there. So if you're not able to get up and walk, of course, your diabetes or your heart disease or your Parkinsonism will be negatively affected by that. One thing that people also don't often realize is that you can pass away because of osteoporosis. The greatest concern with this is to do with hip fractures. And we know that for all comers, regardless of your past medical history, that if you've had a hip fracture, there is a 25% chance that you will pass away within the next year. So 1 in 4 with osteoporotic hip fractures will actually pass away within that year. That is something that we want to avoid, of course. And so we know when the hip fracture has already happened, there is little that we can do to reverse that. So our focus is on prevention and diagnosing this earlier if possible. Now, what about Parkinson's disease itself? So Parkinson's disease and its treatments are both risk factors for osteoporosis. There was a review actually done, which was quite comprehensive by Invernizzi and all. And it showed that over 91% of women with Parkinson's disease actually concurrently have osteoporosis and 61% of men. with Parkinson's disease have osteoporosis. Other studies have looked at this from a different factor as well, and they said, well, what is your increased risk of having osteoporosis? And we see that with Parkinson's disease, your risk of having osteoporosis is almost 2.7. It's 2.66 times higher than the average population. Now, that is not just tied to the disease itself, and it's not just tied to how long you've had the disease. We found in research as well that those who have had a recent diagnosis, so who've been diagnosed in 0 to 5 year mark, have the same risk of osteoporosis as those who've had Parkinson's disease for more than 5 years. So it's not as if you develop Parkinson's and because of your lack of activity or frailty on its own, you develop osteoporosis. There is a connection between the disease right from day one. And again, a reason to be screened for osteoporosis. So what are those risk factors that are there? Well, one of the big ones is falls. And falls is something we are very concerned about. I actually gave a talk previously about falls prevention. But falls are a major concern for fractures because with osteoporosis plus a fall, you're almost guaranteed a fracture. 90% of fractures are from a fall. And Parkinson's, because of the mobility concerns with the rigidity, the slower response times, and often the weakness that develops in your legs, you are at greater risk of having a fall. So that does lead to an increased risk of osteoporotic fractures. There's also theorized a direct link between the disease process of Lewy bodies and the hormonal loss in osteoporosis. Parkinson's disease, so idiopathic Parkinson's disease, the classic Parkinson's disease, and the Parkinson's plus syndromes that we talk about, like supranuclear palsy, Lewy body disease, and such, those are tied to something called Lewy bodies, also known as PIC bodies, that develop within your cells. And as these bodies grow in your cells, the cells die off. It is thought that these same Lewy bodies can develop within your brain area that controls your hormonal release. So because they're also causing that cell death in your hormonal centers, you lose that control of your bones and you develop osteoporosis. Vitamin D is also quite crucial for your bone strength. Vitamin D is something that all of us in North America are deficient in. We just don't get enough sun. We just don't get the right type of sun as well. So we're all quite deficient. But with Parkinson's disease, you have a higher risk of vitamin D deficiency because you're usually more sedentary because of your disease. You're usually not spending as much time outside in the sun to garner that vitamin D. And also a lot of our vitamin D in North America is from our diet. So purposefully, they add vitamin D to all dairy products. Well, when you have Parkinson's, your diet changes, either because of your dysphagia or because of reflux. You know, over 80% of people with Parkinson's have reflux, so they can't handle a lot of things like dairy and such because it flares that for them. And then the other one is constipation. And of course, milk and other things are not great for constipation for a lot of people as well. So because your diet changes reacting to your Parkinson's disease, you often have less vitamin D coming in. And most people are not supplementing on their own for their vitamin D. There's also decreased physical activities. Again, because of the Parkinson's, you're less likely to be active, you're losing more muscle strength, or you're losing more weight, you're more at risk of having weaker bones. And then just speaking to this as before, the change in nutrition and then the weight loss together often cause these concerns with Parkinson's disease and increased risk of osteoporosis. What about the medications? So Sinemet, which is our first-line medication for osteoporosis, does have a connection with low bone mass. It does have an increase of homocysteine levels associated with it. So if you take Sinemet, we know that your homocysteine levels go up. Unfortunately, your homocysteine levels then have a knock-on effect on your hormones that control your bones, and it causes more breakdown and less building up. So there is a direct link between Sinemet and osteoporosis. I want to make it very clear today, though, that this is not a reason to stop taking Sinemet, okay? Though we have this knowledge that Sinemet is associated with osteoporosis, we have to look at the medication and all of the other dopamine medications together as well and say, what is their benefit and what are their risks? So Sinemet, any of the dopamine agonists like pramipexole or ropinirole, or any of the other dopamine-based medications, they all have this risk of increasing homocysteine and causing osteoporosis, but they also have a great benefit towards Parkinson's symptoms. They have a great benefit to improving your mobility. They have a great benefit to improving your quality of life. So when we balance that, it really does tip towards continuing on with your medications. Okay, these medications are far more beneficial than the risk of the osteoporosis. And when we want to quantify that, if we actually look at the FDA data on Sinemet, we know that 23,795 people have actually submitted an adverse reaction or an adverse event response to the FDA regarding Sinemet, but only 0.5% of those people have complained about their bones. Okay, so that is quite a small concern. And the other thing to look at is that though we are worried about osteoporosis, we can screen for it, we can treat it, we can do something to minimize your risks. So it is very much worth it to stay on your medications for your Parkinson's. But if you are on them, have the thought of, I need to think about my bones as well and do everything that I can to protect my bones. Okay, so how do we actually protect our bones? And that's where we talk about treatments. Okay, so the treatment for osteoporosis is a two-pronged approach. It is lifestyle changes and then medications. And from my point of view, lifestyle changes are the most important part of any medical treatment plan. And in osteoporosis, that is even more evident. We know that any physical activity or lifestyle changes that you make are going to be so much more effective than a medication we can provide you. And so that's why they are the foundation for treatment, the very important piece of this. And those lifestyle changes are important in terms of decreasing your risk of falls and increasing the activity of your bones. So minimizing your risk of falls is an important thing to think about and say, what are the potentials within my household that might cause me to fall? What are the things that I'm doing that might cause me to fall? So that's taking a look at your home environment and saying, are there any loose rugs on the floor that I might trip on? Are there wires and cables that are dangerous for me? Is there a poorly lit area where I also always seem to stumble? Is this something that I can change a light bulb or put in a night light? Getting up at night is a common time when people will tend to fall when they're getting up to go to the bathroom. So having yourself with a nightlight right at your bedside table, or having a motion nightlight, so as you walk past it, it turns on, leaving the bathroom light on, things like this are very important in order to decrease your risk of falls. You also want to see what exercises you can do to promote bone strength and muscle strength. Now, these are resistance exercises. So exercises where you are carrying some weight. We also call those weight-bearing exercises. The most common of these exercises is walking. Walking is a fantastic exercise for Parkinson's disease and osteoporosis and minimizing your falls risk. So just going for a walk every day can really help. We know that the minimum amount of walking is actually 20 minutes a day. And it doesn't matter how fast and it doesn't matter how far you walk. It just matters that you are carrying around your body weight for 20 minutes a day. Now, usually when I say that to people, they'll say, well, I'm walking around all the time. I'm going up and down the stairs to do my laundry. I'm out in the garden and such. And that's fantastic. But that is your daily activity. That's not extra. And exercise is extra. And that extra is how you build up muscle strength and how you build up bone strength. So it's important to have that additional walking of just 20 minutes a day. More, of course, is better, but just 20 minutes a day we know does help. And a minimum of 4 times in the week, but again, 7 days a week will get you to stronger bones faster. If walking is not something that you enjoy or not possible because of your health, there are other things you can do as well. Resistance bands are something else that is very helpful. Those are the bands that you can buy from most sporting goods stores. And you can use those to actually work your muscle groups against some mild resistance. If the resistance bands are too easy for you and you are safe and comfortable in using other weights, you can also use dumbbells and other things, because these are providing a greater force on your bones, a greater force on your muscles. So your bones are being encouraged to grow stronger. If working out on your own isn't something that you enjoy, then being parts of classes is a great option as well. Tai Chi has been very well studied and been found to be very helpful for both falls prevention and osteoporosis. The nice thing about Tai Chi is that you can really do it anywhere. I think we've probably all seen people doing Tai Chi out in a park. You can also do it in a gymnasium. You can do it in your own living room. Most people enjoy Tai Chi as part of a group, but you can also just get some videos off the internet or buy DVDs if you still have a DVD player. and just follow along. And Tai Chi is a nice controlled exercise where you are holding your weight and you are slowly moving. And that is all encouraging your bones and your muscles to be strong and really hold that body weight. Other classes that are also very helpful are targeted towards osteoporosis. And the common brand name of that is OsteoFit. That's usually at all of your community centers. A lot of other places will have them as well. But OsteoFit is the one really endorsed exercise for osteoporosis that is a group activity. People often ask me as well when we talk about this, well, what about other exercises that I do? I like to use my bike, or I like to go to the pool and I'm in the water all the time. Bicycling, either on the road or using a stationary bike, is great for your heart, fantastic for your heart. But unfortunately, it's not very good for osteoporosis and it's not very good for your balance. And that's because you're not carrying your body weight. When you're on the bike, you're seated. So your legs are only moving the weight of your legs. They're not moving the weight of your entire body. So you're not gaining that strength. It's a similar concern with swimming or going to aquafit and other classes. When you're in the water, you're buoyant. So you're kind of bouncing along. You're not carrying the full weight of your body. So because of that, that exercise is great for your heart, but it's not doing much for your bones. So if you are using stationary bike or aquafit as your main exercise, if you're worried about your bones, you need to add in something else where you're carrying your own body weight. Okay. Now we talked about minimizing environmental concerns like walking in well-lit areas. Another thing to talk about as well is what type of glasses that you wear. So progressive glasses or bifocals do put you at a higher risk of having an osteoporotic fracture. And that is because it increases your risk of falling. And this is a common thing that we can actually remedy. So when you're wearing your bifocals or your progressives, if you look through the bottom part of your lens, that's your reader. And that's going to be nice and clear up until reading distance. But your feet and the environment around you is going to be fuzzy. So that puts you at a greater risk of fall. So anyone with osteoporosis, we strongly recommend that they switch to 2 separate pairs of glasses, one for reading, one for distance, and only wear your distance glasses when you're reading. I know that's a huge bothersome thing to change for people, especially if you're used to having progressives, or you say, I only need the 1 pair of glasses. I don't need to carry 2. I don't need to worry about losing them. I don't need to worry about sitting on them or crushing them. That is all true. But the risk of a fracture is quite high if you have osteoporosis. So it is something to definitely think about and say, could you make that change to having 2 separate pairs of glasses just to minimize your risk of having a fracture? Gait aids, so things like canes, walkers, and such are also useful, but only if they've been suggested by a professional. I've had many patients who've gone out and gotten themselves a cane or gotten themselves a walker, thinking that they're doing the best for their health and their safety, but they may not be getting the right thing for them. And they may be getting it too soon in terms of not needing a walker yet. And if you get a walker too soon, you end up using it and you end up becoming reliant upon it. So rather than becoming stronger, you actually become weaker because you're not using your core strength to hold yourself up. You're leaning on a walker. Or they may have overcalled it and said, I'm worried about my balance, but I'm not that bad. And they've gotten themselves a cane, which they're not quite ready for and cannot control. And so they actually increase their risk of falls. So my strong recommendation is that if you think you might need a gait aid, talk to a professional. So either talk to your family doctor or your specialist doctor, a physiotherapist, or an occupational therapist, and ask them what gait aid is right for you. And then also you can look into where you can get them as well. Okay, so that last slide was about the foundations of treatment, so the lifestyle changes that we make. Next, we talk about medications, okay? And the first 2 suggestions that we have are just actually off the shelf. So that's vitamin D and calcium. So vitamin D is important because it's a building block. It's a building block for muscles and it's a building block for bones. And we know that most people in North America are deficient, so almost everyone should be on vitamin D, but especially those who are at risk of osteoporosis or already have osteoporosis. The standard dose for most people is 1,000 units a day. And 1,000 units sounds quite large, but it's actually quite a small, tiny little pill. It's only about the size of a baby aspirin, so a very small tablet if you take it. And it is available in tablets or pill forms or gummies or drops. So very easy to take. So if you are someone who's suffering from dysphagia, You could try to take the gummies instead of the tablets if tablets are hard to swallow, because you can chew the gummies, or you can actually use the drops and just drop them into anything that you eat. You can drop them into your liquid, so water, coffee, tea. It's okay to use it with a thickener as well. If you have dysphagia and you need a thickener for your swallowing, you can just drop it onto your food as well and just eat that food. So drop it onto a piece of toast and just eat the whole piece of toast. Or some people just like to take the drops and just put them directly onto their finger and then just put them onto their tongue. So vitamin D is very, very important thing and very easy thing to take. It is quite rare to be overdosed on vitamin D. It can happen, but those are usually people who are taking excessive amounts, more than 7,000 units a day. You should still talk to your doctor about the right amount for you. And depending upon your personal history, they may actually do something called a vitamin D level. So that's a blood test that can be done at Life Labs, or any lab, I should say, that they check your vitamin D level, and then you can supplement and adjust the right amount. And you can check it again, usually after 3 or 4 months, and see, is your vitamin D that you're taking enough, or do you need more or less? So important to talk about vitamin D. I also have a lot of patients who say to me, well, I'm a snowbird. I go down to Arizona or I go down to Florida for 6 months of the year. My first response is, I'm jealous. That's a great lifestyle to have, but it still doesn't give you enough vitamin D. The truth is, it boils down to physics. And in North America, we just don't get the right kind of sunshine for our skin to effectively make vitamin D. So even if you are spending a lot of time in the sun, hopefully with sunscreen, you still don't get enough vitamin D. So you should be taking a vitamin D supplement. And it is better to take your vitamin D supplement all year round, so that you have that consistency of the vitamin D. The other supplement that we take off the shelf is calcium. Now, calcium does need to be dosed correctly for you, and it's dependent upon your diet. Some people take in a lot of calcium from their diet. Some people take in very little. And we know that you can actually take too much calcium. So too much calcium does put you at risk of heart disease. So we want to be able to sit down and say, how much calcium do you average in the day? And then see, do you need extra or not? You want to be taking 1,500 milligrams per day in total from all sources of calcium. So you can, talk to your family doctor about that and see how much calcium you're taking in. There are many lists out there as well through the Canada Health Food Guideline, so through other sources as well, where you can talk to a dietitian and see how much calcium you are actually taking in. I know that within British Columbia, there are always dietitians available for telephone consults too. So you can talk to your doctor about that if you feel that you want to just have a quick chat with someone and say, exactly how much calcium am I taking in? And then how much extra should I be taking? They're usually sold in increments of 500 milligrams. So truth be told, the average person doesn't need more than 1 tablet a day, unless you're having very little dairy or very little animal product in your diet. And even then, most vegetarian diets are pretty high as well. So just be certain that you're not taking too much. So you want to screen your diet and see how much you actually need. Okay. What about prescription medication? So we talked about lifestyle, exercise, the building blocks of bones, so vitamin D and calcium. Now we focus on actually targeting those hormones and trying to tick up those hormones and say, build up more and break down less so that your balance shifts back again. So the medications that do that vary, and there are 3 classes. Now, your physician is the best person for you to talk to about that. And I want to make it clear that everyone is different. So it's not as if all comers need to start with one level and then the next. So really, we'll talk about the different types, but be sure that you ask your doctor which one is right for you. But out of those classes, the first one are the bisphosphonates. Bisphosphonates are alendronate or residuonate. And that is also, alendronate is also known as Fosamax or Fosavance. Many people have heard of that brand name before. Now, these are the medications that we have on our formularies across the province that are the oldest ones. They're the ones that are the best researched. And to be quite honest, they're the cheapest ones, which is why they are the ones that are covered by pharmacare here in British Columbia. So most people will start with these medications because they are covered and because they're the first line medications. There was previously another medication called Didrocal or atidronate. That has now been shown to not be as effective, so people don't prescribe that one anymore. So if you used to know Didrocal, alendronate and residuonate are the newer versions of that, the more effective versions of that. And the way that they work is they actually go into the enzymes that work in your bones, And they tell the enzyme that breaks down your bones, almost like a Pac-Man, to just stop. So they actually slow down the breakdown of your bones, and then they let your body naturally build your bone strength back up so that that balance tips back towards stronger bones. Now, that does take quite some time, and everything with bones takes quite some time. And that's why we usually do bone densities every 3 years. So people will note on a bone density or have a fragility fracture, be diagnosed with osteoporosis. They'll start their bisphosphonate, and then 3 years later, we'll do another bone density. And at that time, we're looking to see what is the change in the strength of your bones. And we're hoping for a response of 3 to 5% increased strength of bones. That doesn't sound like a huge amount, but it actually does translate very well to a decreased risk of fractures. So these medications take time, but they do a good job. The downsides with these medications are that they are once a week. So because they're a once a week slow release pill, they are actually larger pills. They're about the size of a multivitamin. And a lot of people can't handle swallowing that multivitamin sized pill very easily. Because they are bigger, they have a tendency to kind of cause a bit of irritation as they go down into the esophagus. They can get stuck for some people as well. And so they have specific guidelines of how to take them. So you are supposed to be sitting upright when you take it or standing up after you've swallowed it. So you take the medication on an empty stomach, you drink it with a glass of water, and you just don't lie down for at least a half an hour to try and get gravity to pull that pill down. That's the biggest concern, honestly, is the irritation to the esophagus and the fact that it's so large, a lot of people can't swallow it. There are other things that are concerning about bisphosphonates that have really been hyped up in the media. And if you go onto the internet, you'll see quite a bit of concern about these medications. To be honest, from a scientific point of view, that's all been debunked. These medications are not as scary as a lot of those websites make them seem. There is something called osteonecrosis of the jaw, which can be associated with it, which sounds terrible, but is actually very, very rare. So much less than 1% of all people are at risk of that. And that is when you already have concerns with your teeth and you have concerns with bone turnover in your jaw. And these medications will just improve the turnover, but certain parts of your jaw just won't grow at the same rate. So parts of your jaw may actually have loss of bones and other parts will build up more. Again, that's very patient specific. So if you're at high risk because you have major dental issues or you're on other medications that affect your dental strength, so things like chemotherapy and other such things, that's when we worry about that. And that's where your specialist will talk to you about that. But if you read osteonecrosis of the jaw, that does not mean that everyone will get it. Though 10 years ago, this was a big story about these medications, why a lot of people in the public were scared of them. Now, the other options that we have are usually injectable options for medications. Anti-resorptive agents like Prolia are very common these days. Now, Prolia is slightly more effective than the bisphosphonates. It's slightly more effective than the pills. It does show an increased strength of your bones over the years compared to the pills that you can take. It's an injection that you take just into your arm. It feels just like a flu shot. It's a very small needle, a very small volume of medication, and you get it every 6 months, so twice a year. That works out very well for a lot of people because you can time your visit to your doctor every 6 months or so and just get your injection done. You don't have to worry about remembering to take a pill. You don't have to worry about your stomach and such. The only real downside, though, is that it is not covered in British Columbia. And depending upon where you buy it, it averages between $350 and $400. So for some people, that can be quite prohibitive. Very, very, very rare for the government to actually cover it. So unfortunately, that's where we're at right now in BC. We are lobbying to try and get it covered, but it hasn't happened yet. Then after the injections, the other options that we have are the anabolic steroids that we can use. So anabolic steroids probably ignites an image of someone like Arnold Schwarzenegger or Lou Ferrigno, Mr. Olympia, Mr. Universe, because that's usually where we think of anabolic steroids that build up your hormone levels, that build up your muscles and your bones. And that is what we're using, but we're using medical versions of this. So they're targeted specifically towards your bones. One of them is Forteo, which is an injection to your belly every day. Another one is Tymlos, and then the other one is Avinity. Avinity is the newest one on the block. It shows a lot of promise of maybe being a little bit superior to these other medications, but again, has the concerns of needing to be injected consistently. These are reserved for very rare patients. So those who have failed treatment with either the pills or the Prolia injection. So people who've been on the pills or the Prolia injection for years and had no improvement in their bone strength or continue to have fractures, that's when a specialist in osteoporosis will talk to you about these medications. They're difficult to take. They need to be monitored very closely, and they're actually quite expensive. We're talking tens of thousands of dollars overall for these medications. So again, you can know that they're out there, but know that they're not for everyone. Okay. Now, where do you go to talk about all these things? Because I've said several times you want your specialist to review this. Now, osteoporosis is a disease that is covered by many different specialties, but you want to make sure that you have someone who knows it well covering it for you. So there are geriatricians like myself. There are general internists who've done extra training in osteoporosis, usually internists who've done women's health plus osteoporosis, also rheumatologists or endocrinologists who've done extra training in osteoporosis. So if you're worried about osteoporosis, you can get your initial bone density done through your family doctor or any one of your doctors. But if you're looking at treatment, I really recommend having a specialist involved in your care. Most places across the province will have somebody locally who's interested in that. But if you live in an area that does not, know that there are specialists out there. One of the clinics that I run is actually the osteoporosis clinic, along with our sister clinic, the Pacific Geriatricians Group. So if you have questions, you can always ask to be referred there. One of the nice things about osteoporosis is that it's based upon your history and it's based upon your imaging. So you don't have to actually go into Vancouver to be seen. So know that anyone across the province can be seen regardless of where you're from. I'm originally from the north, and so I'm very aware of the fact that you can feel a bit lost in a more remote area where you don't have a lot of specialists, but know for osteoporosis, you can. You can actually see someone through a telephone consult or a Zoom call. Okay. So in summary, we reviewed that osteoporosis is either a history of fragility fracture or diagnosed by a bone density scan. It's a common disease, and everyone over the age of 65 should be screened. And there are some increased risk factors that are out there, like medications or specific diseases. Parkinson's disease and Sinemet are medications and diseases that put you at higher risk. So really everyone with Parkinson's should be screened for osteoporosis. Though Sinemet does have an increased risk of osteoporosis, it's not a reason to stop your Sinemet. It's not a reason to stop any of your dopamine medications. The benefits from those medications from your Parkinson's far outweigh the risks of osteoporosis. So stay on those dopamine medications, but get screened for osteoporosis. The treatment for osteoporosis is focusing on minimizing your risk of falling, and then also improving your bone strength. So resistance exercises, weight-bearing exercises, and then taking supplements like vitamin D and calcium are very important. And then based upon your medical history of talking with your doctor, you can see what prescription medications you actually need. And as I said in the last slide, there are specialized osteoporosis clinics. So try to connect yourself with one locally. If you can't, then you can connect with the one out of Vancouver, which sees people from across the province, to make sure that you're getting that detailed care. All right. Now, that is the end of my summary slide there. So I'm going to scroll back through the chat here and see what questions we have. It looks like the question was if there's a PDF, and I think that that was answered by Alana. Thank you, Alana, for that. The next question, is there a recommended brand of calcium or bone density supplements? There's so many choices out there. How do I choose an optimal supplement for bone density? That's a great question. I could get overwhelmed going into the store looking at all the options as well. To be honest, when it comes to calcium, calcium's a very simple thing. It's not as if you have any benefit from having a special calcium combined with another mineral. So calcium plus magnesium is not any better for osteoporosis than just plain calcium. And it's, as I said, very simple. So you should really just be looking for the simplest version of calcium that you can find at your local store. So just plain calcium, 500 milligrams. And then I would just go with the one that's the lowest cost, because honestly, there's no difference between any of them. Another little trick is that if you have trouble eating calcium, you can also use Tums, the antacid, because that is actually calcium carbonate. So that's another way to get calcium, and it gives you the same amount of calcium as a supplement. But there is no specific brand that is superior. So you don't need to be spending a lot of money on this, and you don't need to be worried about getting the extra bone strength this because of combination with this, that, or the other. None of that actually matters. Okay. Vitamin D tests can only be requested by your neurologist, not your personal doctor. It actually can be requested by any doctor. Life Labs and all of the hospitals across the country actually do request it. You just have to write the reason on your requisition. So I've been able to order it myself as a geriatrician. I've had many of my family practice colleagues as well being able to order it. The thing though is that you have to actually write on that you are doing it for osteoporosis screening, and then they'll actually do the test for you. So it is freely available all across the province. Oh, and say thank you. Somebody added to that any specialist can order vitamin D. So someone is saying that they got coverage for Prolia. What are the risks for this and dental work? So coverage for Prolia is quite rare through pharmacare. So I'm glad that you were able to get that. It does bring up the fact that some third-party insurance covers Prolia as well. So Blue Cross, Manulife and such, some of them cover it. So you may be able to get coverage through that as well. When it comes to dental work and Prolia, there isn't really a big concern, to be honest. You're not worried about osteonecrosis and such. So usually your dentist will be fine with you being on the Prolia. If you're having major dental work, though, if you're actually having dental surgery, your dentist may want you to not be on anything affecting your bones at that time. So if you're having major dental surgery, so, actually getting in there and drilling and removing roots and such like that of multiple teeth, then you want to talk to your dentist and see what their concern is. But for day-to-day work, denturing and the rest of that, it's not an issue at all. So the next question is, how about bioidentical hormones for women for prevention? So this brings up an interesting topic because we did say that osteoporosis is due to hormonal changes, and those lack of hormones can put you at risk of osteoporosis. Estrogen is a real driving force for that. We strongly recommend against any estrogen, whether it be a medical grade estrogen or a bioidentical hormone for treatment of osteoporosis. And that is because of a great increased risk of cancers. So estrogen will help your bone strength, but it will also increase your risk of breast cancer, ovarian cancer, uterine fibroids that can then become cancerous, endometrial cancer, all of these things. It will increase it multifold. And so the risk of increased cancers is not worth the benefit of the estrogen on your bones. And to be quite honest, the alternatives such as Prolia and even the bisphosphonates, alendronate and such, they are not that far behind using estrogen in terms of increasing your bone strength. So it's far better to stay away from the hormones for all women, men as well, because you don't want to be taking exogenous testosterone because that will greatly increase your risk of prostate cancer. So it's a good thing to stick to more of the bone targeted medications. What about Residuonate DR? That's what I was prescribed. My understanding is that it shouldn't be taken on an empty stomach. I think it may be fairly new. Residuonate DR is a newer version of Residuonate. It is something that is meant to absorb better on a full stomach, because one of the great complaints people have about alendronate and Residuonate as their normal forms is that you have to have an empty stomach. You have to take it first thing in the morning. You have to stay upright for half an hour. And Residuonate DR was the pharmaceutical company's response to this and saying this is easier to take and it's actually better to absorb with your meals. It's equivalent to regular Residuonate. It's a bit more expensive than regular Residuonate. And, there's no harm in taking it. It's perfectly a good option to take. It does have a slightly increased risk of causing a bit of reflux, though, because of the coating on the medication. But if you don't have reflux, you're not worried about that. But other than that, it's a good option to take. Okay. The next question is, how does family history of osteoporosis impact your potential to develop osteoporosis? So a family history on your mother's side does put you at an increased risk of osteoporosis. We usually quantify this as a hip fracture. That is because we're looking at the worst consequences of osteoporosis. So if your parent had bad osteoporosis, they likely had a hip fracture. So you're considered high risk from that. And it's also because, honestly, for the generation before us, we didn't have very good screening for osteoporosis. So most people didn't have a bone density. So they didn't know they had osteoporosis. They just thought they had a broken bone. And a lot of it was normalized. So any history of having a fracture from your parents is an important thing to let your family doctor know. And if it is a long bone, so if it's a hip fracture, a thigh fracture, or a humerus fracture, an arm fracture, it is a reason for you to be screened when you're over the age of 50 for osteoporosis. What foods and drinks should I avoid if I have Parkinson's and osteoporosis? Example, coffee. To be honest, with osteoporosis, there aren't any foods that we specifically avoid. There are foods that we encourage. So we encourage things that are calcium rich, and we encourage things that have vitamin D added to them. But coffee or other carbonated things have sometimes to be considered to be weakening of your bones. That's never been shown to be true in the large scale studies. And so it's not enough for us to say avoid the foods. And it's not enough to say that it actually affects your calcium absorption. So nothing specific to avoid for osteoporosis itself, but more of an encouragement to try and take in more dairy as best as you can, or other things that are high in calcium, like cauliflower and such. The next note is a very nice thank you note. So thank you, Diane, for those kind words. I appreciate the thank you there. All right. Now, if there are any other questions, I'd be happy to take them now. I think we have a couple more minutes.
You can also raise your hand if you have difficulty typing. We can also answer questions through that function. So the raise hand function.
There is a question. Do you suggest taking magnesium as well? I do not suggest taking magnesium as well, just for osteoporosis. Calcium is an important part of this, but magnesium is not as crucial. As well, with magnesium, you can have some downsides. If you take too much magnesium, you actually trigger diarrhea. So I only suggest magnesium for those who are truly magnesium deficient. And that's a very rare subset of people. The next question is about OsteoStrong. I'm sorry, I haven't heard of OsteoStrong, so I'm not sure what that is in reference to. So apologies, I'm not able to answer that question. So Levodopa seems to be a med ordered. What is the difference? So Levodopa is just the generic name of Sinemet. So levodopa carbidopa is just the combination that is Sinemet, and that's just a generic name. So there's no real difference between levodopa and Sinemet.
So we have a question from Frank.
Mm-hmm.
So Frank, if you could unmute yourself.
Okay, go ahead.
And then go ahead.
I have been diagnosed recently with what's it called?
Which one are you talking about? Heart? Cancer?
Cancer of the prostate.
Mm-hmm.
And they've decided that it's a very strong type of cancer, and they've decided to put me on a hormone suppressant.
Mm-hmm.
And they suggest to counteract that, I take a lot of calcium
Mm-hmm.
to prevent osteoporosis.
Mm-hmm.
And now I'm wondering, I've also had a heart event. I have 2 stents put in.
Right.
Taking a high dosage of statin. What's it called?
Statin.
It's 84 milligram.
Yeah.
Probably Lipitor. Yeah.
Atorvastatin, I believe.
Yes. Yes. That's Lipitor. Yes.
So what about the conflicts there? Is calcium gonna?
Yes, you have Parkinson's.
Yeah. Yeah. So I would say that it depends upon how much calcium you're actually getting in from your diet, right? So if you're getting in a fair amount of calcium from your diet and then you're taking too much extra, so if you're getting more than 1,500 milligrams in the day, that is overshooting it. And that is at the point where we're worried about your heart, especially with your personal history. So you'd really have to go through with your doctors, your diet. And if you're part of the cancer agency, they usually have dietitians available to you as well. So you could sit down with them and just go through your average diet and see how much calcium you're taking in. And if it is too much, then you don't need to take the extra supplement. And the other thing is most of our patients who start on any sort of hormone lowering medication for cancers, usually you get a baseline bone density as well. So we have an idea of what the bone strength is today or now as you're starting. So you can see how big of an issue your bones are and how diligent you have to be with the extra calcium.
So I should ask for that for a bone density check.
I would suggest it, yeah.
And right now I'm taking 650 milligrams of calcium through the day, like 2 different times.
Yes.
And plus, I think there's in the morning one is 300. So that's about 1,500.
Yeah, just on its own. I would suggest talking to a dietitian or to your doctors there and see how much you actually need to take.
Okay.
Yeah. Thank you for your question. All right. The next question is, I have hemochromatosis and avoid iron. Okay. And I'm sorry, Mary, I'm not sure what context that one is in. But hemochromatosis is something that can change your diet. And if it means that it has the knock-on effect of you taking in less calcium, then it would be something to look into in terms of your bone strength. Another question is, what is my opinion on zoledronic acid injections? So zoledronic acid injections are an option. So zoledronic acid is in the same class as the pills. So alendronate, residuonate, and zoledronic acid are all very equivalent. Zoledronic acid is nice in that it's an infusion, an IV infusion that you just have once a year. Most people aren't going for it because of the difficulty with getting it arranged, especially during COVID. The number of injections that people were able to arrange during that time was quite difficult. Zoledronic acid otherwise, though, is equivalent to taking the pills. So if you have the preference of taking the injection every year rather than taking the pills, you can go ahead and do that. The only other downside, of course, again, in British Columbia is that zoledronic acid is not covered. So you have to pay for that one yourself, which is usually between $300 to $400 to get the infusion done. And then if you're able to go in and get it done at a hospital, then it's covered. If not, then sometimes there are costs to get an infusion done at an outside infusion center. Okay. So what about omega and turmeric? So unfortunately, omega-3 and turmeric have no effect on your bone strength. Omega-3 is great for managing your cholesterol and such, but it has no effect on the hormones that manage your bones. And turmeric is a good anti-inflammatory, but again, not any effect on your hormones. The other interesting thing about turmeric is it's actually just the pure turmeric root, which has been shown to be very helpful as an anti-inflammatory, but the turmeric that you take as a supplement usually isn't as effective as the pure root. But either way, neither of those have an effect on your bone strength. Okay, I believe we've gone through all the questions. Alana, I don't know if there's any more that you've seen.
No, I think we just have some. Oh, there's
one more. The concern of protein significantly interfering with dopamine medications. When and what form do you suggest protein be eaten? That's a question outside of bone health. And that's something I think a lot of people with Parkinson's disease struggle with. It's a hard one. I think really it is trying to space out your protein as best as you can from your Sinemet, but realizing that it's not possible to completely eliminate it from each meal. So most of my patients, I suggest trying to have at least one meal a day where you have protein intake, and realizing that that particular meal and that time Sinemet might be the best absorption, but it's kind of the balance of needing your protein and also needing your Sinemet. So usually I suggest taking one meal a day where you have your big protein load. Okay. I think those are all the questions.
I think so too. Thank you so much, Dr. Parmar, for a very informative presentation. Lots of good information there and advice. Thank you all for attending today's webinar, and I hope you have a great afternoon. Thanks so much. Bye now.